Hi, I'm Marnie Engel, volunteer specialist at HSC, and I am pleased to introduce you to Dr. Oksana Sikorsky, who will be presenting Juvenile HD. How is it different? How is it the same? The objective of the session on juvenile Huntington disease, or JHD, is to review the various symptoms of JHD. The presentation will also compare and contrast the clinical features of JHD with adult onset HD. Participants will learn key features of JHD and its similarities and differences to the more prevalent adult form. Dr. Sikorsky is currently Professor of Medicine in Neurology, Medical Genetics, and Pediatrics at the Faculty of Medicine, University of Alberta. Dr. Sikorsky received her MD from the University of Calgary. Following a residency in neurology and fellowship in neurogenetics at the University of British Columbia, Dr. Sikorsky was recruited to the University of Calgary Faculty of Medicine to develop the Movement Disorders Program in 1984. In 2010, she was recruited to the University of Alberta to expand the Movement Disorders and Neurogenetics Program. Her research interests include understanding genetic factors related to the development of neurodegenerative disorders, in particular Huntington disease, and developing new treatments for these disorders. Let's get right to the session. Dr. Sikorsky?
Great, thank you for that great introduction. And it's my pleasure to tell you a bit about juvenile Huntington's disease. And I just listened to the HD Buzz session that preceded this session, and what a wonderful talk that was with all the research that is going on in HD, and what a great group of young researchers and clinicians that are involved in this area. So their talk was mainly about adult onset Huntington's disease. So I'd like to switch to a topic which doesn't really get as much attention maybe as it should, and hopefully that we can help to change this and provide more information and research into juvenile HD. So the title of my talk is to bring you up to date with diagnosis and treatment, but also to stress what is the same between adult onset and juvenile onset, as well as what is different in the two disorders. So first of all, my disclosures, just so you're aware, I am doing research with Wave Life Sciences, with Brain Canada, with CHDI and Enroll HD, and with Roche. And AbbVie is Parkinson's disease, so it's not related. So first of all, we all know that Huntington's disease is an autosomal dominant disorder, and that the age of onset is dependent on the size of the triplet repeat. But generally, we concentrate on the lower end of the repeats, 40 to 50 repeat sequences. And this is a slide taken from the original Jim Gozella work, who first described the gene that causes HD, showing the age of onset on the left on the vertical axis with the number of repeat size on the horizontal. And as you can see, generally people who have 40 repeats have an age of onset around 50, although there is a large spread all the way into the 70s, and sometimes we see younger patients with 40. But when you get to the very high repeats, that is about 50, 60 or above, that you can see that the age of onset drops below 20. And what we know that in very young onset, juvenile Huntington's onset in young childhood, that the repeat size is 80 or above, and can even be as high as 174. I think that's the highest repeat size that has been described, as 174 repeats of this expansion. So just to give you some definitions which are important, when we talk about juvenile Huntington's disease, what we mean is that the onset is before the age of 21 years of age. So adulthood, according to this definition, begins at the age of 21. But we can further subdivide it, which is important to look at the symptoms, and that is childhood onset, which begins below the age of 10, and adolescent onset, which is defined as 10 to 20. And other times, some people define it as pediatric Huntington's disease, which is below the age of 18. So I think the definitions are important into how we categorize the symptoms. And I will be using the definition of juvenile HD or JHD as beginning before lower than 21 years of age, with childhood onset less than 10 years of age, and adolescent onset 10 to 20 years of age. So that is the general definitions that are most commonly used at this time. Now, how common is Huntington's disease versus juvenile Huntington's? So the latest papers that have been done, and there was a paper very recently published in the last few months coming out of Calgary by Tamara Pringsheim, showing that the overall prevalence, which means how many people are living with Huntington's disease right now in North America and Europe, how many are alive with this condition? And depending on the study, it varies between 5 to 10 per 100,000. And using 38 million people that live in Canada right now, we expect anywhere between 4,000 to 8,000 people in Canada who are affected with HD right now. Now, juvenile HD is uncommon, and only 5 to 10% of all people with Huntington's have onset below the age of 21. And I suspect that it's at the lower end, that it's not at the 10%, but it's at the lower end, closer to 5%. So by calculation, it is estimated that there are about 200 to 300 people with juvenile HD living in Canada right now. So you can see that that is quite uncommon, and that there are not many Huntington specialists that would have looked after or are looking after patients with juvenile Huntington's disease in any one place in Canada. And that is one of the issues that will come up as I go along in my talk, that to get a good experience in what the symptoms are, what the best treatment is difficult when you've only seen a couple of patients, a handful of patients with juvenile onset in your career. Okay, so first I'd just like to remind you of the clinical features in adult Huntington's disease. And there's been a lot of studies on this. We know those symptoms very well. It typically, in adult onset Huntington's, symptoms start with chorea, the small, irregular, restless movements that are present in HD. The dystonia refers to abnormal postures, typically seen in the hands, sometimes in the feet. And then as the condition progresses, you can get some stiffness and slowness, which is called rigidity or bradykinesia. You get more problems with swallowing, with walking, as well as slowness with eye movements. Cognitive symptoms typically begin with behavior or judgment or insight, and then you can have a variety of psychiatric changes such as personality changes, depression, which is part of the condition as well as a reaction to being diagnosed with HD, irritability, obsessive compulsive behavior. And then the column on the right shows us the symptoms that we now are much more aware of, as opposed to, say, even 10 years back. Weight loss, which is very common, apathy, fatigue, and pain. So these are the motor features of Huntington's, beginning with very mild symptoms with restlessness, then chorea, and then late stage, where the chorea may get less and the person begins to look more like somebody with, for example, Parkinson's disease, and may even be misdiagnosed as having PD. And we also know that Huntington's does not start suddenly. It starts very, very gradually. And those of you that attended the HD Buzz talk also heard about the pre-symptomatic stage, where the person has no motor or abnormalities or symptoms, but there may be some the beginnings of the deposition of the toxic Huntington protein, some shrinkage of the caudate and putamen, the parts of the brain first involved in HD, then the prodromal symptoms where we may begin to see some suggestion of symptoms, and then the frank abnormalities. Okay, so now let's switch to comparing it to what we see in juvenile Huntington's. So first of all, in the motor symptoms, if you remember that the most common symptom is chorea that we see, well, we don't see chorea in juvenile Huntington's. What we see is slowness and stiffness. So bradykinesia refers to the slowness of movement. Brady means slow, kinesia movement. Rigidity is the increase in tone and stiffness that we see in the limbs, as well as dystonia, which is the abnormal posturing. So the symptoms both in the childhood as well as the adult onset Huntington's patients is Parkinsonism, meaning slowness and stiffness of movements. They look like someone with Parkinson's, as well as dystonia, the abnormal posture. There is no chorea. Okay. The other thing that we see is seizures. So children with Huntington's will, about maybe a third to half of them, will develop seizures, particularly the younger the age of onset, the more risk of seizures. We don't see seizures in adult Huntington's patients typically. So this is a major difference in the clinical features that we see compared to adults with HD. Okay. In cognitive symptoms, we don't see things like problems with judgment and insight because children are just developing those. What we do see is developmental delay in development of new skills. So for example, learning language, learning to read and write, even learning motor skills, some motor skills, learning how to do things. And then in older individuals, just learning difficulties that they used to read well, they can't read well anymore, that they can't do their arithmetic anymore. So it's quite a different picture where it's we see problems in either learning new skills or loss of previously learned skills in school, as well as not developing new skills. In behavior, again, it's different that we don't see the problems with sort of maybe irritability and anger outbursts that we can see, but we do see acting out, particularly in teenagers. We do see some obsessive compulsive behaviors. Less commonly, we can see psychiatric issues or depression. So this just gives you a sense of that the presentation is quite different. And when we see somebody with juvenile Huntington's, they look actually quite different than someone with what is commonly seen in adult patients with Huntington's. So what is the same? So family history. Yes, juvenile onset HD always has a positive family history. In adult onset, we usually do. Now, this is a little bit different, so we usually see family history, but sometimes we do see in the very low range of of triplet repeats, say 38, 39, that they may not have a family history of Huntington's because the gene hasn't expanded yet to that stage. It's the first generation where we see the genetic expansion. So the core presentation is the triad of cognitive, behavioral, and motor symptoms. So there's a triad in both, but again, as you saw, the triad of what those symptoms are different. There is a gene expansion, yes, but the gene expansion in the juvenile onset is usually 50 or 60 or higher, whereas in adult onset, it's about in the 40 to 45 range typically. Is there a correlation between repeats and age of onset? Yes. But unfortunately, the progression, although is seen in both adults and juvenile Huntington's, the progression is faster in the juvenile Huntington's. So this just points out the differences again. So adult onset 40 to 50 repeats typically, juvenile onset often above 55, although we sometimes do see juvenile onset in the a bit lower range, not sure why that is. And whereas we don't see adult onset in sort of in the high 50s or 60s. The inheritance pattern, while it is an autosomal dominant, in adults, we see 50% like inheritance from 50-50, both equally from the mother's side and the father's side, whereas the inheritance pattern in juvenile HD typically comes from the father. And this is an important point that if we see a patient with juvenile onset, young onset, almost always it is the father that carries the gene, the Huntington's gene expansion. And the reason for that is that the repeats can be unstable and they can get larger, sometimes smaller, but this happens in sperm and not in eggs. So in men with Huntington's disease, if say they have, well, let's just take it as an example, 45 repeats, then their sperm, some of them will have 40, 45 repeats, some of them will have 50 repeats, some of them will have 60 repeats. So it depends which sperm fertilizes the egg. And because of this large instability in sperm, that we see children with young onset that have inherited the gene. In the eggs, the repeat size stays fairly stable. There may be a little bit of increase, but not nearly as much. Okay. Now, the next area where there's a significant difference is the initial motor symptoms. So as we discussed, chorea is the main one in adult onset Huntington's. Gait problems, as well as dystonia, as well as slowness and stiffness are the main initial motor symptoms. And in addition, what we see is significant slowing of eye movements. So when you watch a person with juvenile HD look back and forth, that their eye movements are quite slow, and they sometimes have to use their head to move their eyes. We do see this a little bit in adult onset Huntington's, but not as much. And then there again, you can see the seizure prevalence that at least a third of children with HD will develop seizures, whereas in adults, it's the same risk as anybody in adulthood has of developing seizure because of other factors like strokes or tumors or just a genetic predisposition, other genetic predisposition. Okay. This slide shows you the rate of progression. So while both are progressive, you can see there that in the red line is the patients with juvenile HD, that the rate of progression is faster than in adult onset HD, which is the blue line. And again, this just shows you the same thing in a box plot. Now, so that's the differences between juvenile in general, juvenile HD and adult HD, but let's look at the childhood onset versus adolescent onset. And this is important as the younger the child is with onset, the symptoms are a bit different, and the older the adolescent is, for example, if they're 20 going into 21, years, then there may be more of a overlap with what we see in adulthood. So these, while I'm talking about groups, it's not sort of a straightforward this group, this group, this group. I mean, we have to think of it as a continuum of symptoms with more slowness and stiffness, gait problems in the younger children, and then merging into more adult type of symptoms when you hit into adulthood, young adulthood, although you may still see some of the more symptoms we typically think of as juvenile. So it is a continuum of symptoms depending on the age of onset. But in children, we definitely see that the first sign may be gait impairment. So they have difficulty with walking. Whereas in adolescents, only 35% of them will have difficulty walking at onset. This is the beginning of the symptoms of HD. We never see chorea in children. Whereas, as I mentioned, if the adolescents are like 19, 20, then you may see some chorea at onset. Developmental delay is 90. We see this very commonly in children where they just don't develop new skills. We don't see that in adolescents because they've developed all their skills. More, it's a loss of skills. Obsessional behavior. So children don't develop as much obsessive compulsive behavior, but 73% of teenagers will develop obsessive compulsive behavior. And this seems to be a fairly typical symptom as they as they're adolescents, so they become fixated on something, and that it becomes a problem. The other thing we sometimes see in adolescents is difficulty with manipulating their hands. So if they were sort of good, they like to play with Lego or build models or things like that, or maybe even play computer games, that they lose the ability to use their hands in those activities. Again, seizures comes up where the majority of, sometimes a seizure may be the first presentation of juvenile HD in children. Let's look at cognitive and psychiatric symptoms, because so far we've concentrated mainly on motor symptoms, but up to 70% of children may present with non-motor symptoms, just like adults may present with non-motor symptoms with psychiatric and cognitive symptoms, although the symptoms, as mentioned, are different. So decrease in school performance is common. Behavioral changes, acting out, like I said, obsession compulsive. And it's important to remember that psychosis, schizophrenia, and depression are actually rare in early stages. And schizophrenia and depression are not uncommon in teenagers. Development, for example, schizophrenia, when it first comes on, the first signs of schizophrenia are typical in late adolescent, very early adulthood. But schizophrenia is not typically a presenting feature in Huntington's disease. Similarly, many teenagers do get depressed, some suicidal. It's rare as a presenting symptom in early stages of Huntington's. Other symptoms that do occur in children and adolescents are sleep disturbances, that their sleep gets disrupted. That may be a sign. pain is not something that we have that has been concentrated on much in either childhood or adult onset Huntington's. And some patients do complain of pain, sort of a non-specific pain. This is something that probably people that we should be doing some studies on to see the prevalence, the type of pain, what the best treatment is. Itching can be a symptom. I'm not sure what the cause of that is. It's been reported in the literature. Weight loss, which we know is a symptom in HD, but is more severe in children, and tendency to constipation may come on. Okay. So how do we diagnose Huntington's, juvenile Huntington's? And I think you see that in children, particularly younger children with HD, that typically Huntington's wouldn't be at the top of the list in many scenarios. The reasons for that is that there's overlap with common problems. There's many disorders that have similar symptoms to what I just talked about. For example, some of these children may have been diagnosed as cerebral palsy. People would be looking for other hereditary disorders, other sort of causes for inflammation, for viruses. So there's overlap with a lot of other neurological conditions, as well as with psychiatric and cognitive complaints. And, you know, with autism, with learning difficulties, there's a lot of other conditions that would be diagnosed before somebody would think of Huntington's. The other issue is that in somebody, say, if the father has 40 repeats and the child has 80 repeats, then the child would develop symptoms of Huntington's disease before the father. So the father would not have a diagnosis of HD, but the child will already be developing symptoms. So in some situations, we do see that the age of onset in the child can be earlier than the age of onset in the father. And we do have seen cases like this. So when say a pediatrician is taking a family history, they would not realize that there may be history of Huntington's disease in a grandfather or grandmother, or go back, or even farther back, that they may not realize that there is a family history of Huntington's because the father looks fine. The other cause is that pediatricians and pediatric neurologists may never have seen a case of Huntington's. They may not know, they may be taught in medical school that chorea is associated with Huntington's and the child does not have chorea, so they wouldn't think of Huntington's. So the fact that the symptoms are completely different is not well recognized. And like I said, our pediatric colleagues, most of them would never have seen even an adult, let alone a child with Huntington's. So because of this, that there frequently is difficulty with diagnosis. And there is, it's been reported about 5 years between the onset of the symptoms to a diagnosis of Huntington's being made. Sometimes it's not until the father gets Huntington's, develops symptoms of Huntington's, that somebody makes the connection. Okay. Now, I'd also like to tell you about what is not juvenile Huntington's, when not to worry. First of all is tics. Tics are very common. These are very brief, rapid, stereotyped twitches, typically affecting the head, neck, eyes. When you see them, they look quite different than chorea does. They're typically associated with an urge to have the tic, and then the urge goes away. Tics are very common in children, like 3, 4, 5-year-olds. When you watch them, a lot of children will have tics, like these are called transient tics of childhood. Children typically will outgrow them. Sometimes they don't, and they go on to develop Tourette syndrome, but tics in themselves are not signs of Huntington's and typically, okay? The next thing is tremor. So we sometimes see little tremors in children. Again, this would be very unusual, very uncommon to be a sign of Huntington's. So tremors are not Huntington's. Spasticity, which means that's sort of typically associated with cerebral palsy. There's some other genetic disorders that cause this. Multiple sclerosis can cause this. So again, this spasms in the legs typically would not be associated with Huntington's. Huntington's patients don't have spasticity. Eating disorders, common again, or not uncommon in children, teenagers, not associated with Huntington's typically. And also isolated depression or schizophrenia, as I already mentioned, is typically comes on in teenage years. So one of the important things when a person or a physician is wondering about whether this could be juvenile Huntington's is to really see whether there are typical symptoms of Huntington's, of juvenile Huntington's, as well as whether there's progression for over a year. So even if you see tics or tremors, but they don't progress over the year, then this would not be associated with HD. So I think there's other things that we can use to rule out a diagnosis of Huntington's clinically. So when do we offer a test for juvenile Huntington's? So as you can imagine, being an adult with a risk of HD, how stressful it is to wait for the test. When I tell someone that I think they may be having symptoms of Huntington's and that I may be, and I want to offer a test, that it is very stressful. And I appreciate how stressful it is waiting for that result to confirm the diagnosis. And to test a child is even more stressful. As a parent, to think that your child may be developing symptoms of Huntington's is unbelievably stressful. So we don't want to use the test inappropriately. And also when we're doing genetic tests, we're obligated to tell the parents what we're testing for. So you can imagine that if the child has just atypical symptoms, no progression, no family history, that is just not appropriate to test the child for HD and to put the parents of the stress of something that isn't really associated with Huntington's. However, when there is a positive family history, there are two or more of the symptoms that I mentioned. The child has been monitored, other conditions have been ruled out, and the symptoms are progressive, that's when the test should be ordered. So we certainly don't want parents waiting 5 years to wait for the test to be done. But at the same time, we don't want to test, put other families through stress if this just isn't Huntington's, right? So it has to be done judiciously by physicians that are familiar with this condition, with appropriate counseling. The other thing that we do not do in children is predictive testing. So I run the predictive testing program in Edmonton. We routinely test adults who want to know whether or not they have the gene, the HD gene, before they develop symptoms to do life planning. But we certainly do not test children. It is not appropriate to tell a parent of a child whether or not they have the gene for HD if we know they're not going to develop symptoms until they're in their 50s or 60s. I mean, that is sort of incredible, inappropriate stress to put a child and family through that. Now, treatment of Huntington's is similar whether it's an adult or a child. It is done through the Huntington's disease clinics across Canada, and certainly juvenile Huntington's, I would suggest, should always be treated in one of our Huntington's clinics in Canada due to interdisciplinary management with neurology, psychiatry, nursing, physio, occupational therapy, social work, dietitians. One of the problems is that all of us right now that work in Huntington's disease have been trained in adult neurology and adult psychiatry. So we do need to bring in our pediatric colleagues into this, but I think that these children definitely deserve interdisciplinary management. Ongoing psychosocial support through the HD Society is invaluable, and Huntington's Canada certainly is a wonderful resource for us in supporting social work, among other things, information and conferences such as this. And then the other important thing is to refer to the medical genetics department for appropriate genetic counseling for the parents, for the SIBs, for other relatives, because obviously when we see one child with HD, then there will be others that need to be examined, may need to be tested, may need to understand what is going on from a genetic perspective. So treatment there is no specific treatment that has been developed for Huntington's, for juvenile HD. The important thing is to avoid certain medications to not make the Parkinsonism worse, physiotherapy for gait abnormalities. If the dysphagia, if the swallowing gets worse, swallowing assessments, working with a dietitian, a feeding tube. And I'm sorry, the slide has been cut off, so I can't see what's at the bottom there. Weight loss needs to be managed. Right now, we do not have apathy or fatigue, any management for apathy or fatigue. If there are psychiatric features, then we can use, usually the drug is quetiapine. There may be other drugs that our psychiatric colleagues use or would suggest. Cognitive impairment in Huntington's, we do not have any medications for cognitive impairment at this point, but for depression, anxiety, behavior problems, there are medications we can use, and again, that would need to be in consultation with our pediatric psychiatric colleagues. So as you can see that there's many challenges in juvenile HD. First of all, that it is uncommon, and I mean, we would have only a couple of patients in the province of Alberta right now with juvenile Huntington's. Diagnosis can be difficult because the initial symptoms mimic other childhood and adolescent problems, and there may not be a family history. Our pediatric colleagues may not be aware of the presentation. But genetic testing should not be done until the physician is very suspicious it is HD, and hopefully we can, with appropriate education, we can cut this down to 1 year or maybe 2 years from 5 years. The research is difficult because there's so few patients, right? And we don't have the validated scales. You know, I mean, many of you, I'm sure, are familiar with the UHDRS, the Beck Depression Scale, the Total Functional Capacity. Well, these are all adult scales. None of these relate to children or would be useful in children. And no one has developed rating scales as yet for children. And then treatment options, the best treatment options, we don't know, because all we know is what is used in adults. So in conclusion, that juvenile HD has distinct clinical symptoms from adult symptoms, but that this is a spectrum, and the symptoms overlap between juvenile and adult HD in the late adolescence and young adulthood period. Diagnosis remains a challenge, as we heard. Genetic testing should be done with a positive family history with 2 or more symptoms with progression. And lastly, I think that it is very important to develop international collaborations to look at the challenges that I mentioned. And I think through Enroll HD that we should be able to develop a group that is specifically interested in juvenile HD to develop better scales, better treatments, and to look at research. I think generally the FDA, Health Canada, other organizations are very resistant to doing research on children. But I think in this situation where we know we have a specific diagnosis, we know that progression is more rapid than in adults, that I think that these concerns should be overcome to help us develop improved treatments and potentially a neuroprotective approach. So thank you very much. I'm for your attention, and I'm happy to answer a few questions.
Thank you so much, Dr. Sikorsky. The first question that has come in is, are there any studies on better treatments for JHD?
Right now, I'm not aware of any. And as I mentioned, I think that Enroll HD would be a perfect venue to pull out the children. And, I would like to personally take the children, the adolescents, and the young adults and look at those groups specifically to see what treatments have been tried, what treatments work. And I think that through Enroll HD, we should be able to get a good cohort. I think one of the problems in particular is seizures. So when a child with HD develops seizures, we don't know which anticonvulsants, antiepileptics to use and which work best. And some of these children develop very severe seizures that are very difficult to treat. And I think that would be the first place I would start. It's sort of interesting how when you do a talk like this, you start thinking about what are the areas of need and what could be done. And I would say that the first thing that I could see doing is pulling all the patients with seizures to look at what anticonvulsants have been tried and we would be the best to use, because this is a real need. And I've had a number of juvenile HD patients in hospital with seizures, and we just don't know which antiepileptic to use first, which one would be most effective. So that would be a place I would certainly start.
Terrific. Thank you so much. We do have another question. What do we need to do research in this area?
Well, first of all, I think we need to educate our pediatric colleagues about how to make the diagnosis and when to think of this diagnosis and when not to think of this diagnosis. And then to make sure that all patients with juvenile HD that we do have a good database on, so that we could look at potential research strategies. I think right now in Enroll HD, from what I remember, that we don't have to register children. I think that a number of centers only are registering adults. And I wonder if we should revisit that and look at looking more at children, getting a good database of children that may have HD or at risk for HD, to have a good population that could be, could we ask to volunteer for research? For example, if we do find a drug or treatment in adults that looks promising, I think it would be very good to be able to try them in our juvenile HD patients sooner rather than later.
Well, thank you. Thank you very much, Dr. Sikorsky, for that informative presentation. I'm just going to check our chat just in case we have Yes, we do have one more question. Can you elaborate on regarding pain and what we are now learning? So what can you elaborate on regarding pain and what we are now learning?
Yeah, unfortunately, I can't elaborate very much because that's an area that really hasn't been looked at very much. And so I know that I've had several patients, adult patients, that have complained of sort of a pain that's sort of pretty nonspecific, but can be quite marked. Um, I don't, we don't really know how many patients suffer from pain, what the best treatment is, what could be causing the pain. I know some of my pain, now these are adults, right? These are adults that have been using cannabinol oil. Sometimes we try drugs like gabapentin. I think that's another area that really has not been studied as much as it could be. And I think, again, with the meetings like the Huntington Study Group, like Enroll, that we can start looking at different symptoms and try to get a better handle on it. But that's another area of need.
Thank you. Thanks very much. So thank you to Dr. Sikorsky for that informative presentation. And we're grateful for you for sharing your expertise in the field.